that's all there is, John.
Okay, so first of all, could I ask you to introduce yourself, just your name and your institute, just for our records?
So I'm Dr. Bernard Escudier. I'm working in Gustave-Roussy Institute in Paris, which is a big comprehensive cancer center.
And you're giving a talk on the general scene for kidney cancer in 2014 today. Can you tell me about that?
Yeah, so it's a difficult lecture I've been asked to do. So what is the situation of kidney cancer in 2014? What I'm going to cover is, first of all, kidney cancer in 2014 is a lot of unsolved questions. So we have made a lot of progress, but still we have a lot of questions. The first question is, we have new genes coming, which are new actors in the disease. And one of the questions is whether these genes will be targets for kidney cancer treatment. Are they prognostic? Are they predictive factors? So that's one of the points I'm going to cover. Then I'm going to go through different questions we have. The first question we have in kidney cancer is, should we observe the patient before starting treatment? And observation is an important question in many patients with kidney cancer. And that's one of the points I'm going to try to cover. Then I will go to some of questions about surgery. Should we still remove the primary tumor when we have kidney cancer with metastatic disease at onset of the disease? Then I will go through the choice of treatment in first line, in second line. When should we switch from first line to second line, which is a very common question that medical oncologists ask experts to solve. And finally, I will put the scene by what is going to arrive in the next 5 years from now, and hopefully, I will introduce what Martin Gore will say in 2014, which is his lecture. So that's probably what I'm going to cover today.
Mm-hmm. So what are some of these genes or biomarkers that we're using which we might target?
So we have two quite important genes. One is called BAP1, which is a new gene discovered in the past 2 years. The second one is PBRM1. And these two genes, interestingly, are in the same chromosome than VHL. And VHL has been the important gene for years now in kidney cancer. And interestingly, these genes are mutually exclusive. So when you have mutation of one of the genes, usually you don't have the other one, which is mutated. And one of these genes, which is PBRM1, is a good prognostic gene. So if you have kidney cancer with these genes, your expectancy of life is much better than if you have the BAP1, which is mutated, which we still don't know, but probably, this gene has some function. And interestingly, if we can find out which is the function of these genes, then we can probably find out some targets for treatment. That's what happened with VHL, which is one of the genes for VEGF pathway. And probably we are, very shortly, we are going to find out what are these new genes doing.
Mm-hmm. So there's people studying this, investigating this?
Yeah, a lot of people are working on that.
So you mentioned about the potential for monitoring the patient before treatment. What's your opinion on that?
So one important observation is that some patients have very slow growing disease. And question is, when should we start? You observe patients, so then the year after he has a 1 millimeter increase in the tumor. So when should we start? I'm going to present 2 cases from my own clinic, which put me in trouble recently because I'd observed 2 patients and then they developed suddenly very new site of disease. And we'll present 1 bone and 1 brain met. And I'm going to show some of the data we have about the tumor burden, which is probably one important question. So if we have too much tumor burden, so the size of the tumor is too big, we probably have to treat patients. And the question is, which is the tumor burden that we are going to trigger? And one question we have for the next coming years is, can we predict when a patient is going to develop a new site of disease? Is it a question of tumor burden? Is it a question of some other prognostic factors? So that's really an important question for us.
Mm-hmm. So are there set sizes for the tumor? Are there guidelines that exist that you can?
There is no guidelines.
So do we need
so in the guidelines, what we put in the guidelines, European as well as NCCN, is that as kidney cancer are very indolent disease, you should observe patients when they have indolent disease. But we never put in the guidelines, when we should start treatment. And that's one point we have to detect in the future.
Okay. And you're also giving a talk on the ideal bevacizumab patient.
So yeah, tomorrow I'm going to give a talk on which is the ideal bevacizumab patient, because interestingly, I mean, this drug has been the first one to be shown to be active in kidney cancer, and actually it's very little used. And my lecture is going to be why it's little used and why it should be more used. Because in fact, when you look at the literature, I mean, that's the drug which has the more data. So we should be convinced. I mean, that's a good drug. It's very selective. It's very well targeting VEGF, which is the main target we have. It's not a dirty drug like other drugs which have a lot of side effects. So there is no reason. And I'm going to try to explain why I think most of the patients should receive bevacizumab. Of course, it's going to be a little provocative because still, I mean, people are going to use oral drugs. But I think it's going to put people in the context that maybe we are not doing what we should do. So that's going to be my take.
What would be your argument for that?
So I think one of the arguments, which is honestly what is my real gut feeling, is that drug companies are doing most of the marketing. So when you have three choices, which is actually the case in kidney cancer, you can use sunitinib, you can use pazopanib, and you can use bevacizumab. So when you have three choices, of course, you have different options to select your drugs, but one very important one is the drug company marketing, because all these drugs are quite comparable in terms of efficacy, honestly. So if you have one drug company which is very powerful, which put a lot of pressure, then probably you are going to use more of this drug. So then you will have, of course, a question of cost, a question of, but power of marketing is very important. And that's one of the points I'm going to say.
So it's important to look at the science more than the marketing.
Yeah, but the science is not always answering the question. So when you have equivalent drug, I mean, then the marketing is important. Mm-hmm. If you have a drug which is much better than the other one, I mean, you don't need marketing, of course.
So for your talk, back to today, what will be the concluding points for a physician watching this?
So I think they are going to go with some of the new information we have on genes. They are going to get some information, I hope, on what is going to be the new field of research in the coming years. And I will conclude by saying, I mean, in 10 years from now, I'm sure that we'll have a lot of answers to this open question, and Martin Gar is going to give the answer in his talk.
Okay, that's great. Thank you very much.
Okay.
Thank you.